Hello, let's talk about aplastic anemia. Aplastic anemia is essentially an autoimmunity against bone marrow. It's T cell mediated following exposure to an antigen that creates a breach in self tolerance, and we call that sensitization. So your body will get exposed to a shape, whether it's a drug or a protein on the surface of a bug, a virus. And that shape will be shaped similarly to a shape that is present on cells residing in the bone marrow. And when your T lymphocytes recognize that shape, they will attack your bone marrow because they think they should be attacking it. They've been sensitized. When that happens, you get a pancytopenia, eradication of all three of the big cell lineages that arise from the bone marrow: your red cells, your white cells, and your platelets. So the symptoms of aplastic anemia have to do with that pancytopenia. Because you lack red cells, you will have a hard time oxygenating your body. So extreme fatigue is a noteworthy presenting symptom. Because you have no white cells, you will be unable to fight off infections. And a lack of platelets presents commonly as frequent and prolonged bruising or ecchymoses of the skin, reflecting an inability to clot and stop even minor bleeds. Now, aplastic anemia and bone marrow failure in general can be inherited, and there are a few conditions that present with aplastic anemia at a very young age that we'll go over. But most commonly, it's acquired following sensitization to a drug or a bug. And this table lists common causes. You can see these are some frequently used drugs: chloroquine, that's an anti-malarial; naproxen, that's a non-steroidal anti-inflammatory; anti-seizures, anti-epileptics such as carbamazepine can cause an aplastic anemia; anti-thyroid medications like PTU and methimazole; anti-diabetic drugs and carbonic anhydrase inhibitors, as well as some fairly prevalent infections, all of the hepatitis viruses: cytomegalovirus, EBV, herpes zoster. So half the herpes family, all the hepatitis viruses. But by far the most prototypical offender that creates aplastic anemia following its clinical use is chloramphenicol, which is an antibiotic. It's a 50S ribosomal inhibitor. It's bacteriostatic, and we really don't use it for much anymore because of the high risk of aplastic anemia. But it is a pretty good treatment for Rocky Mountain spotted fever. That is a tick-borne infection presenting with a rash that starts on the hands and then spreads to the trunk. So chloramphenicol is also associated with gray baby syndrome, which is a skin discoloration. And those two things in concert in a test question, it's aplastic anemia. Still going over the risk factors: benzene, which is a chemical used in manufacturing; the hepatitis viruses, Parvovirus B19, add that to the list. What's the pathogenesis of aplastic anemia? Lymphocyte activation and T cell mediated attack on hematopoietic cells. So it's a type 4 hypersensitivity. It's T cell mediated, but once it gets going, it's going to take out marrow all over the body. There is an affinity in these patients, or an association rather, with HLA-DR2. T cells overproduce interferon gamma and TNF alpha. These cytokines suppress hematopoiesis, and they also induce apoptosis amongst red cell, white cell precursors and megakaryocyte precursors. So marrow failure then is what we call the state of not having circulating blood cells from all types. Before we dig any further, I would like to take a look at bone marrow in aplastic anemia. On the left, some normal bone marrow. We see large pockets of fat, marrow's fatty, with these densely nucleated cells within. Those are your erythrocyte precursors, your lymphocyte precursors. And in aplastic anemia, you can tell that this is a hypocellular marrow. There's not a lot of maturing cells in here. Little packet right there in green, but mostly this marrow is adipose. It's been wiped out and it's empty. Another example of the hypocellularity, just not a lot in there. Many empty spaces. And if you get a photo of this on a test question, you know there's something wrong with the marrow. You'll probably also get a lab value that's going to say reticulocytes are very low. Now, aplastic anemia is a normocytic anemia, and that means that, well, your MCV after CBC is your first step in working up anemias. Now, if the mean corpuscular volume comes back within normal limits, you're going to do further workup. And specifically, you want to get a reticulocyte count, because if it's normocytic, bone marrow problems are on the table. So a low reticulocyte count will tell you there is something wrong with this patient's bone marrow. A high reticulocyte count would indicate there's no problem with the bone marrow. Look elsewhere. But a low reticulocyte count, again, might be reflective of the early stages of iron deficiency anemia and anemia of chronic disease. So an iron study is a good call when you're working up any normocytic anemia as well. But then a low reticulocyte count can also herald aplastic anemia, as well as anemia related to chronic kidney disease. Think about why. It's because kidneys make erythropoietin, specifically interstitial cells of the juxtaglomerular kidney. And if your kidneys are hurt, you're not making that hormone EPO, which is what tells blood cells they need to mature. Without EPO, red cell precursors commit apoptosis. So that's why chronic kidney disease also, it looks like there's a marrow problem there. Back to the slides. One practice question I'd like to share. A 12-year-old girl brought to a pediatrician because of a recent onset of bruising. The daughter has had a recent infection developed on a trip to Guatemala that was treated with an antibiotic. Now the girl is presenting with non-blanching purple and yellow bruises on her legs. So you take a CBC and you realize she's anemic. It's normocytic, but her white count is depressed as well as her platelets. So this fits a pancytopenia. And you put that together with the sudden onset of widespread ecchymoses, and you ought to be thinking aplastic anemia high on the list. So then the question asks, what's the MOA of the antibiotic that was given to this patient for her prior illness? And so understanding chloramphenicol is one of the highest yield drugs they like to test on this pathology, is going to lead you to the mechanism of binding the 50S ribosomal subunit. Back to the SDL to talk about some heritable forms of aplastic anemia. First off, there's Fanconi anemia, and this is autosomal recessive. It's due to a problem in DNA repair. And clinically, there is a stereotypical presentation. First and foremost, there's a pancytopenia. If there's not a pancytopenia, it's not really Fanconi anemia. There are some characteristics of Fanconi anemia, including cafe au lait spots. A lot of diseases can have those. What's very telling are hypoplastic thumbs. You get limb deficits on the radial side of the upper extremity. So this is a picture of a patient who has Fanconi anemia, and there are no thumbs. In the upper right here, we see very short thumbs, underdeveloped compared to the other digits. Now, there's your cafe au lait spots in the middle panel here. And if you were to take this patient's bone marrow, you see it's washed out. It's got a very fatty marrow with sparse hypocellularity. So that's the presentation of Fanconi anemia. Autosomal recessive, and the genes here, let me unmark this, are real cool. They are called Fanconi A through Fanconi N. So no trouble remembering that. So they won't ask you that. I mean, it's named after the disease. So they want you to know the mechanism. It's DNA repair. Couple other things you can get with Fanconi anemia: horseshoe kidney, duodenal atresia. So I shout those out just in case you see the question. What other symptom or anomaly might the patient present with? Complications of Fanconi anemia include the later development of leukemia, which is a white blood cell cancer, mainly acute myeloid leukemia, which is the one that presents typically in adulthood. Most common leukemia of ages 15 through 50. And AML is the one with hour rods inside the myeloblasts. And hour rods they look like gout needles, but in a white blood cell. So, gout, it's got those birefringent needles on polarized light. And you'll see these needles inside a blood cell, and they're not crystals or inclusion bodies. They're lysosomes that have taken on an abnormal elongated formation. So that's AML. It's the only leukemia that they want you to associate with hour rods, those lysosomes. So that was Fanconi anemia. Again, short or absent thumbs, horseshoe kidney, duodenal atresia, and of course pancytopenia. It's autosomal recessive DNA repair defect. Now let's talk about dyskeratosis congenita. So congenita means that it's apparent right away. Dyskeratosis, well, kera, that means keratin, that means skin, something like that. And so something's going wrong with your skin, and it's a chronic process. It's an osis, it's a condition. So this is an X-linked recessive disease that is a problem in telomere maintenance. And telomeres are these repeating sections of TTA, GGG that you have at the ends of your DNA. And there's a certain amount on them, and they protect the DNA by allowing it to continually divide over and over again. Because when you run out of room at the end of the DNA, your processor, your polymerase can't lay down anymore past a certain point. And so that's why we have telomeres, is to give your polymerases kind of room to work at the end of the DNA so that all of the coding region of the DNA gets conserved from replication to replication. And if you lose anything, it'll be the telomeres that get lost. So that's what's messed up in dyskeratosis congenita. Again, you'll have a pancytopenia with a bone marrow failure, and you will biopsy it in order to see what's going on. And when you biopsy it, there's nothing in this bone marrow, very sparse hypocellularity. Now, there are some characteristic findings for dyskeratosis congenita, like there are for Fanconi anemia. You've got nail hypoplasia, meaning that fingernails and toenails just don't grow in correctly. And that's pretty particular to this disease process, especially when combined with the pancytopenia. You see dyspigmentation of skin, a little bit broader, more widespread than just cafe au lait spots. Here's another patient that has hypoplasia of nails, especially on the toes there, and dyspigmentation around the collarbone. You see a dark spot and a very light spot on top of that, then another dark spot. And leukoplakias of the tongue are also common. So again, heritable pancytopenia with an increased risk later on in life of acute myeloid leukemia, AML with hour rods, and characteristic symptoms: skin pigmentation, nail dystrophy, leukoplakia. So thinking about those two familial aplastic anemias, the questions I would ask if I were asking them, you could ask, what's the gene? What's the mechanism of the gene that's deficient? What other symptom or sign might the patient have? And what other cancer is the patient at risk of? But other than that, findings are pretty obvious. Pancytopenia, nothing in the marrow. Patients with aplastic anemia present, again, with very extreme fatigue. They feel terrible because they don't have a lot of red cells, and so they're very poorly oxygenated. And the brain is one of the organs that's going to suffer first with generalized moodiness and concentration difficulties. And also because of the low platelets, these patients do bruise very easily. Another characteristic symptom, you see easy bruising, you're thinking of plateletopathy. And leukemia does present very similarly, especially with the easy bruising and the potential for a cytopenia, because leukemia can grow in the bone marrow and eradicate marrow. And so something similar is going on in that pathology. So you definitely want to rule that out when you're getting that marrow tap. Splenomegaly is characteristically absent. If they have a big spleen, it's probably not aplastic anemia. And because the bone marrow has been wiped out, you can't make reticulocytes. Going back to how we started, first you get the MCV, then you get the reticulocyte count. If it's really low, you know there's a problem with the bone marrow. Now, the severity of the disease is going to be assessed on biopsy based on the cellularity of the bone marrow and the total neutrophil count systemically and platelet count as well. So how do we treat aplastic anemia? Remember, most of the time it's acquired. So what we would do is immunosuppress the patient in cyclophosphamide. An alkylating agent is a good drug of choice for that. And then we would hopefully perform a hematopoietic stem cell transplantation. Now, the immunosuppression goes a long way by itself because that kind of resets the immune system and cools it down. And so if all of the T cells that are agitated against the bone marrow go away, maybe the next batch of T cells you pop out will not be so focused on attacking the bone marrow. That's the thinking behind the cyclophosphamide. And stem cell transplantation is curative, totally curative, 80% of the time. So a good prognosis if patients can follow through with the treatment plan. And it is a tough treatment plan. You're immunosuppressed, you're getting a transplantation. It's basically like you have a cancer. You're going to be on chemotherapy and you're going to feel very bad with nausea, vomiting, etc. That's aplastic anemia, the hallmark of which is pancytopenia. Now let's discuss pure red cell aplasia, which is very, very similar, but you're missing the leukocytopenia. You're missing the thrombocytopenia. You've got white cells and you've got platelets in circulation. The only thing messed up here are the red cell precursors. So it will present, obviously, as an anemia, and you'll get MCV, and it'll be normocytic. So you'll get a reticulocyte count, and you won't see any reticulocytes at all in the blood. So pure red cell aplasia is high up on your list. Then you'll get a bone marrow biopsy and you'll look and you'll see white blood cell precursors and megakaryocytes in the bone marrow, but a thorough lack of red cell precursors. And that's going to let you hone in on pure red cell aplasia, the fact that white blood cells and platelets are normal. Again, bone marrow is normal cellular, and there is a heritable version of pure red cell aplasia that's called Diamond-Blackfan Anemia, which is a ribosomal structural defect leading to p53 activation, which triggers early apoptosis of red cell precursors. So, interestingly enough, I said heritable, but in the majority of cases, Diamond-Blackfan anemia is actually due to a spontaneous mutation. It can be familial, and it is autosomal dominant when it is, but usually it's a spontaneous mutation. So Diamond-Blackfan anemia patients have a characteristic finding called the triphalangeal thumb. So a phalanx, that's just a bone of a finger. You've got your carpals, right? Your metacarpals, and then your phalanges. And normally your thumb's got 2 instead of 3 phalanges, but in the setting of Diamond-Blackfan anemia, it's got 3. So it's virtually as long as every other finger on your hand. And this patient on the right actually has a supernumerary thumb for a total of 6 fingers. But on the left, you can tell that this patient, their thumb is basically like their ring finger or their pointer finger. So that's the hallmark of Diamond-Blackfan anemia. Cleft palates, microcephaly, also common. Congenital cataracts. So wide variety of non-specific congenital findings, and then that triphalangeal thumb gives it away, along with the anemia. So Diamond-Blackfan is the heritable form. You can get acquired pure red cell aplasia out of nowhere, RKO out of nowhere, and it's usually linked to an autoimmunity such as lupus or a breach of self-tolerance following an infection or a drug. Now, the most common infection that is going to give you an acquired red cell aplasia is Parvovirus B19, because this virus has tropism for red cells and red cell precursors. It attaches to the surface P antigen, gets inside the red cell, kind of like how Plasmodium does, and destroys them from the inside out. That's the parvovirus aplastic crisis that is most commonly seen in patients with sickle cell anemia, because they have a tough time making red cells as it is. So you throw parvovirus in the mix and then it's even worse. So B19, what else do we remember? Fifth's disease, rash that starts on the face, moves downwards. It's a single-stranded DNA virus, the only single-stranded DNA virus, and it's a naked virus, as well as a Torches virus. And it can really mess up your bone marrow. I have found a couple of images of parvovirus infecting red cells. Here's one from a peripheral smear, and here's really the cell that we're looking at. You can see inclusion bodies inside the nucleus of that red cell. Here's another affected cell, big old bodies in there. This looks like one to me right there in the top left. A whole bunch of just dark nuclear inclusions as a result of that parvovirus intracellular infection. Here's the same thing. There's an inclusion body. There's an inclusion body. That's a red cell precursor on a peripheral smear. We're thinking parvovirus. Now let's discuss myelophthisic anemia, which is essentially a mass lesion in the bone marrow. The most common causes of a space-occupying lesion in the bone marrow, number one, is going to be primary cancer from elsewhere that metastasized to the bone. So then remember, it can be clastic or blastic, lytic or blastic, really, and that prostate cancer really likes to be blastic. It might be a primary bone cancer. It could be miliary tuberculosis, which is, let's talk about that. What is miliary tuberculosis? Well, TB follows a characteristic course. It's respiratory transmitted. So primary TB always starts in the lungs, and you got a Gone complex, right? It's a little calcification, and primary TB starts in the lower lobes. Now, in 9 out of 10 patients, that TB goes latent and then might reactivate later. But in 1 out of 10 patients, the TB just gets worse and worse and worse from the get-go. It never goes latent, and it starts disseminating throughout the body. That's miliary tuberculosis. Now, where does TB go? Everywhere, just everywhere. It can go to your adrenals. It can give you Addison's. It can go to your spinal column. It can give you Pott's disease. And it can go to your bone marrow, where it could give you this myelophthisic anemia. Now, Gaucher disease, that's brought up here at the top of page 9 as something that could also eradicate your bone marrow. What is Gaucher disease? It's a glycogen storage disorder, or a lysosomal storage disease rather, in which you can't degrade this compound called glucocerebrosidase, or glucocerebroside, right? So you're lacking the enzyme glucocerebrosidase that's supposed to cut them apart in the lysosome. If you can't do that, they accumulate and cells die because of that. And characteristic of Gaucher's are these macrophages that have a tissue paper cytoplasm, right? Looks like you took a notebook paper and just balled it up and then put it on a screen, and that's your cell. Okay, that's Gaucher disease. So into the story, myelophthisic anemia is anything that's going to cause a mass lesion in the bone marrow. And patients present with signs and symptoms that reflect the underlying medical condition. So that's really all that we have to say about that. There will be some anemia. There might be a low platelet count. There might be a neutropenia. It's more so a stick and move and see what's up, rather than you're going into this, oh, I know exactly what it is. And that's about all we got on these bone marrow normocytic anemias. Thank you.